Welcome into another edition of BR Ortho Talk. Glad to have you aboard with us. And today we are pleased to be joined by anesthesiologist and pain management specialist, Dr. Kelly Boussert. How are you?
Doing well. How are you?
I'm doing awesome. I
Good.
am really looking forward to this conversation because
Uh-huh.
I am someone who, for years, even though I'm only 41,
Yeah,
have lived in chronic pain. So I know there's a lot of people that are going to be able to relate to this.
absolutely.
I want to start though by talking a little bit about you. I think one of the things I've really enjoyed about doing this series is getting to know the doctors as well,
Yeah,
because so often we get to know you all in these little short windows
right,
in an exam room or whatever it may be.
right.
So who are you? Where are you from?
So I grew up in Ruston, Louisiana. I grew up there. I have three sisters, a big family. We went to school in Chicago or LSU for my medical school, and then I went to Chicago for an anesthesiology residency, California for an interventional pain fellowship. And so then my husband's from Baton Rouge, born and raised. And so when we were trying to decide where to live, I decided to move back closer to home. So then when we have vacation, we could travel, and we love
Sure.
to travel and things like that. So now I work for Baton Rouge Orthopedic Clinic and doing pain management for them. I have four little kids. My oldest is 7, and then I have a set of twins who are 5 and a 2-year-old.
You're not busy at all.
Yeah, so it's pretty busy but fun, and yeah, they make life interesting always, and it's been great. I've loved the group that I've worked with at the orthopedic clinic. The sort of colleague interaction that has been very helpful to, when you have questions about patients, to be able to bounce ideas off of each other or say, hey, I don't know if this person needs to be seen quickly or not, kind of get somebody in quickly, or get another set of eyes on somebody. It's been very collaborative, and I've been really happy with that. So
So go back. So you're one of 4 girls.
I'm one of 4 girls.
So my
Yes.
wife is one of 3
Oh
girls,
yeah.
and I'm curious if your family is the same. I always say you don't know where one family ends and the next begins
Oh,
because they're
absolutely.
all so
That's
close.
right. That's right. I know. I think my husband, when we all get together, is just like, what is going on? Yeah.
It is
It's just yeah, you can not see each other for, 6 months, and it's just everyone's talking over each other, and
Yes, it is
yeah,
overwhelming and
yeah.
loud
Yeah. Oh
a
yeah. And
lot.
my mom's one of 10, so lots of, yeah. I mean, it's fun. So
Did so you came to LSU, you said you went to Chicago. Where were you in Chicago? Where were you in school?
I was at University of Chicago
Okay.
in Hyde Park.
Was what was your first winter like in going from
Oh
Ruston,
my
Baton
goodness.
Rouge to Chicago?
Yeah, it was a shock. There was a blizzard, and the trapped us all in the hospital for 3 days, and I had to. I mean, they couldn't get any trains in, and so I had to walk. When we finally got kind of out of the hospital, got to walk um, to the train that was about a mile away. I felt like the grandparents saying how they walked through the snow to get to school. But we really had to do that, and after that, the winters were snowy, but not as dramatic.
Yeah.
But yeah, I loved it. I loved the snow. I loved the change in seasons. I just it was a great. I was there for 3 years, and then I did a fellowship in California after that. So a big juxtaposition with the weather situation.
Where were you in California?
So I was at Stanford. So
Okay. Northern
and
Cal. Yeah.
yeah, and Palo Alto, and I mean the weather was just unbelievable, just perfect.
You
I mean, every day I walked out, I'm like, it's the same perfect
yeah,
weather. It
I
was,
know.
it was kind of lost track of time because I couldn't. It was every day was the same, but
You
it
went
was
from
cool.
blizzard to wine country,
Blizzard to
basically.
exactly, absolutely. It was a fun year too. So
I always find it interesting though because so many of the orthopedists at Brock and the doctors at Brock have amazing backgrounds, like what you described. Right? University of Chicago, Stanford, these amazing institutions of higher learning, so much experience. And then it's always interesting for me to learn what brought people back to Baton Rouge and
yeah,
brought you to Brock. So, what was that decision like for you and I presume for your family?
yeah. Um, we took a lot of things into consideration. We're both very close to our families, and so family is a big pull. I realized that living off, anytime we would have a vacation, we would come home to see family. So we were really never traveling anywhere else. And so I knew that would be what it would be long term. Anytime we had a break, we would come home, and we ultimately wanted to have kids and wanted them to kind of know their aunts and uncles and grandparents. And going away too, I think makes you appreciate home more. So I realized, as exciting as Chicago was in California and as expensive as they were, we could maybe, find a place where we still felt like we could travel to all of those exciting places and do all of those things later in sort of shorter spurts, but on a day-to-day basis, be close to family, be close to, I mean, people in Louisiana are just awesome. They're unique, they're open and welcoming, and I'm not from Baton Rouge, so when I moved here, I mean, people invite you to their dinner clubs and their house for a crawfish bowl and to watch a game, and it's just a very, very friendly group of people that really, after traveling other places in the world, it's not always like that.
Yeah.
So I think there's a lot of, just good, genuine people here, and family, and that's what brought us back.
So what did you always want to be a doctor? Did you not always know you'd go into medicine at some point?
I did not. I thought about it some during college. I worked with an OBGYN and in the summers, and I really liked that. I really loved the patient interaction. I thought it was just interesting, challenging, all of these things. I thought that could be an interesting career, but I was actually an English major in college. I always was more interested in reading than science, and so I didn't even. I think I took one science class in college, and I was an English major. I thought I'd do something with that. I taught English for a year after graduating college, and then realized that I was not meant to be a teacher. I loved it. I appreciated it. But I kept thinking back to sort of when I would work in the clinic and the challenge that I felt seeing patients, and I felt there was a lot of similarity. It's this service industry and calling, and you're taking care of people just in different ways. I thought it would open a lot of doors. My mom is a nurse. She had always kind of mentioned it, and I didn't really take it too seriously. But then after you're out on your own and you're paying your own bills and thinking about career choices, and I thought, well, let me just see. I'll take science classes. I took science classes for a year, and then the MCAT, and went to medical school the next year. So I worked in the emergency department too, and
Wow.
I just loved the excitement. Everybody was just, it was something different every night, and I passed out the first time I saw blood. Like, it was just, and then it was a huge learning curve. But then I realized, oh, I can do this. I can. Every time you see something, you learn from it, and then you get better, and you add that together. And yeah, I don't know. That's how I came.
You passed
that.
out the first time you saw blood?
I did.
How in the world?
Well, it was a baby, so I feel like it was crying, and there's
Sure.
blood, and so I just hit the floor. They called me Crump in the ER for that whole year. So that was embarrassing. When I told them I'm going to med school, they were like, "Oh, good luck."
Well,
But,
typically,
yeah.
so like I'm a journalism major. English reading, comprehension, all that stuff
Yeah.
were my strong suits. Science was not one of them. It's
Right.
usually
Right.
kind of an either or thing.
Right. I think I think people are probably more inclined naturally toward one. But if you have an interest in language, you have an interest in learning, you have an interest in reading, I think you can learn anything. And then when when I would be in a science class, I wasn't always interested at first, but then when I would learn the application of the science, and now and in medical school, when I started to see how it impacted people and how I would apply something we learned in science to the actual person and the history of medicine, I thought it was fascinating. And so it was, I think you can learn anything if you apply yourself enough to it and put the time in. And I always loved school, and I like to study, and so that part was fine. And but the application of it, the art of medicine, they say, is the continuous learning. So I feel like you get to sort of be a continuous student as well. And
Why did you choose anesthesia?
So I chose anesthesia. Probably because it was the last rotation that I did. And every rotation I did, I loved it. I would, do surgery and love so many things about surgery, pediatrics, internal medicine, everything. When I did anesthesia, it was at the end and I was excited about it. It was time to start applying for residencies. And I also loved the options that it held. I loved the procedural aspect of it, the idea of putting someone to sleep and waking them up at the end of surgery and everything that happened in between was fascinating. I liked the options though that it offered later. If some people love the operating room, and I love the atmosphere in the operating room. It's great working with surgeons, and people are very passionate about what they do in there, um, and but then there would be the option to work in the ICU if you didn't want to stay in the OR, and then to do pain management. And I'd worked in the ICU and pain management as well in medical school, and thought, I hadn't quite fully decided what long term I would love the most because I hadn't learned enough yet. And I knew it would give me possibilities to sort of pivot into more patient clinic care or ICU, or stay in the OR and work, with people after that in that environment. I knew I wanted to have kids. I thought this will allow me more flexibility with my schedule or more autonomy with my schedule, and that's not always the case with certain disciplines unless you maybe find the right group.
Listening to you talk about kind of being so interested in learning, kind of like the perpetual student, like which
Mhm.
we should all be in life, right?
Right.
It is interesting that, and it makes so much sense that you chose pain management
Oh,
because it feels like that is an ever evolving and maybe a rapidly evolving field.
absolutely.
Do you
Absolutely.
agree that even I would say in a relatively short amount of time, you've seen advances in that field?
Huge advances. Yeah. And I think I, I I think there has not yet been enough research into it, and there needs to be more, obviously, because we still don't understand enough about it. I think that's actually one of the major lures to pain management is the challenge of it, the idea that we really don't understand chronic pain enough. We don't understand why some people have chronic pain with the same degenerative findings on MRI that somebody else and someone else with the same findings does not have that chronic pain.
Hmm.
Why the experience of pain is so different for so many people. It is the major cause of disability in the United States, and so major cause of people missing work, being out of the workforce. So it's really a huge problem that we try to address kind of with what we can, with the tools we have, with the knowledge we have, but it's incomplete knowledge and it's evolving. So we're still learning. That's exciting. There have been some newer advancements. Even the older treatments that we have are getting better. So we're still learning, and that's very hopeful and exciting. But it's still not quite where it needs to be in terms of being able to fix everybody. We learn to kind of manage the pain, but not always fix it as well as we could to get people sort of back to their full function.
Yeah, I'm excited about this opportunity to talk to you because I'm probably going to speak on behalf of a lot of people listening or watching us
Yeah.
because I'm 41
Hmm.
and I live with chronic pain.
Yeah.
Uh, knee, back, like, and I've had it for as long. I can trace it to being about 14, 15 years old having back
Wow.
pain,
Yeah.
and it never goes away.
Right.
So, and I've tried like everything you can imagine.
Hmm.
So when we talk about advancements, that makes me very hopeful. So I know one of the things that you do is the intercept procedure. Can you
Right.
explain? That sounds like a big fancy name. Like, can you
Yeah.
explain simply like what that is and what it does?
Yeah. So the intercept procedure is it's a newer procedure. It's been studied in really well done studies for a number of years, but only available for the last year and a half or so. I think that we've been doing it, and it is a targeted treatment for vertebrogenic low back pain. So what that means is it starts as degenerative disc disease. Anyone who has degenerative disc disease that's painful, the discs over time release kind of chemical mediators that irritate the lining of the vertebrae, and those are the bones and the spine that are stacked. When that happens, you get swelling along the edges of the bones. So we call them end plate changes or modic changes, and it's something you can actually see on MRI. So you know if someone's going to be a candidate for Intercept, if Intercept should help them, if you see this swelling in the vertebrae beside that degenerated disc on their MRI. And we've seen them forever. You've seen the modic changes forever and ever, but no one knew how to treat it. And so we don't even comment on them with the radiologists and for a long time because there was just really nothing to do for it. Now, they're, the realization that, hey, maybe because bone pain is very painful, maybe that swelling in the bone is what's causing someone's pain when they're sitting for a long time, when they're standing for a long time, when they're bending forward, when they're putting on socks and shoes, loading the dishwasher, going for long drives. When these things are painful, maybe it's not just the disc itself anymore. Maybe it's the swelling in the vertebrae, and there is a nerve that runs through that vertebrae. So because of that, we can burn it. The exciting thing is that nerve does not have a myelin sheath around it, so it doesn't grow back. So when you burn it, it's done. That you just one burn, and not like the other. A lot of people are familiar with radiofrequency ablation, rhizotomies, nerve burns, but those are to the joints in the back, and those grow back. So you kind of have to keep doing it over the years. So this would be permanent, and it's an outpatient procedure to tap a little needle into that bone, burn the nerve, at whichever levels you have those modic changes in the low back. It's just approved for the low back, and then you go home and that's it. Most people I see are getting 100% pain relief. I mean, it's dramatic. We at least hope for kind of 60% relief, but it should help pain and function tremendously, often within 2 weeks, but it can take up to 3 months to sort of see that benefit.
So if I have one, and this may be a common misconception, I'm wondering if you hear this. I feel like I'm almost in like a consultation right now,
Yeah.
because that'd be perfect for
No,
this.
yeah.
So like when I think about like burning a nerve or blocking a nerve, I think, okay, well, I know my nerve is there, or if I have pain, that's my body's signal saying, hey, stop doing what you're
Yeah.
doing. Something's wrong.
Yeah.
So if I burn that nerve, and I'm turning off that signal, essentially,
Are you
am I
gonna
still
pause?
doing things that are hurting
Correct.
myself?
Yeah. So, that's a common question, and understandably, but no, because that nerve, now that you have swelling in the bone, that nerve is being stimulated all the time, saying it hurts all the time, everything you do. Even non-painful, typically non-damaging things are still causing pain because you have swelling in a bone. That's extremely
Like
painful.
putting on my shoes.
Exactly. Like that's not causing damage to your back, but it's telling you that it hurts more than it should because of the degenerative disc kind of causing that swelling along the bone. The other thing is you have so many other innervations, so many other areas that have nerves to tell you when something's being pulled, overstretched, understretched, all of these things. You have nerves to the discs, you have nerves to the joints, you have nerves to the muscles, you have nerves to the other levels that don't have the modic changes. So your spine is going to let you know if you're doing something dangerous still. There's no worry about that. The difficulty in treating spine pain is that it's so complex. So it's not going to be as simple as burning one area, the nerves to one area, and then not having those normal, healthy, necessary pain signals to protect you.
When people talk about back surgery, it's very scary. I mean,
Yeah.
that's a feels like a really big deal,
Yeah.
right? If you can lay on a table and have your back operated on, and you mentioned like spinal cord. what is spinal cord stimulation?
Yeah. Spinal cord stimulation. So this is again, an outpatient procedure that an outpatient procedure where we put leads in the back. They're kind of like little wires in the back through an epidural needle, so kind of similar to having an epidural, putting the wires through it. And there are little electrodes on the wires that send signals through the epidural space into the spinal space where the spinal cord is. Those signals go through the spinal cord to the brain and transmit signals, non-painful signals to the brain, so that essentially, and it's much more complex, but essentially it overrides the brain's ability to sense the typical pain signals. Not any type of pain. I mean, if you fracture your spine or something, you're going to
Sure.
feel it. If you herniate a new disc, but the chronic pain impulses that you've had for years, if you have chronic back pain
Mm.
or chronic leg pain, that are continuously sending painful signals to the brain, then this creates a non-painful stimulus in the legs and back to essentially suppress the others because the brain is picking up on these newer signals.
Wow.
And it's really cool. It's a permanent, I do a trial first, so you don't have to do anything permanently until we know that it helps you, but then we do put it in permanently. So it's a little more invasive than some of the other procedures because it needs to be implanted. But once it's implanted, everything's under the skin. You have uh, kind of a remote control that you use to turn it off, turn it on, turn it up, down, change. You can reprogram it for different types of pain that you might have. It's just another tool that has been tremendously helpful for people. It's approved for failed back syndrome, so that just means, or post-laminectomy syndrome, and that means after you've had a back surgery in the neck or the back, then and you still have pain, then a spinal cord stimulator would be an option. Also for a condition called complex regional pain syndrome, CRPS or RSD, the older name for it. That's a nerve pain condition that's sort of unique to the extremities. Spinal cord stimulation helps tremendously for
Mm.
that, and then and then also for peripheral neuropathy. So diabetic peripheral neuropathy, peripheral idiopathic peripheral neuropathy. You just don't know why you have it, but damage to the small nerve fibers in your hands or feet. It's very helpful for that. So it's not necessarily a replacement for surgery. If surgery is indicated and an option, then and you have pain going down the legs, especially, or a lot of various conditions that you need surgery for, it would not replace that. But in a lot of people, surgery is not an option. And
Mm.
if they see a surgeon, they say it looks terrible in there, but there's too much going on. Surgery wouldn't help. It's just your pain is just in your back. It's less likely to help with that, and we wouldn't know where to start. If you're not a surgical candidate, then it's a great alternative. I'm actually seeing it help a lot with scoliosis, patients with scoliosis, and that's been a really
Mm.
tough thing to treat.
Yeah. One of the things that was interesting about your answer there is you were talking about sort of varying degrees of pain
Yeah,
and what might be what type of pain might be a candidate for what intervention. So, at what how do you advise people? Like, I think everybody, as you age, you live with some sort of pain.
right.
Right? There's part of that is just
Yeah,
getting older, or at least maybe that's what we tell ourselves.
yeah,
But at what point, or what are some signals or signs that people should know to say it's probably time to go get this looked at?
yeah. Um, I think when it starts interfering with your normal activities, things that you love to do, or your function. If you like to exercise and you can't exercise, if you can't pick up. I see a lot of kids or younger patients that say they can't pick up their kids. They can't get on the floor and play with their kids when they're young, and that's something that they should be able to do. When you stop, when you're not able to sleep at night because of the pain. It's waking you up at night. You have to have sleep, and every time you roll over, pain is waking you up. If you find yourself having to take a lot of medication, there are treatments to help avoid, medications and even over the counter medications that people think are safe. I mean, A lot of times people are taking high doses of NSAIDs, ibuprofen, Aleve, things that'll hurt your kidney and your stomach lining and cause ulcers. That's not necessarily the best maintenance for pain. There might be other options. So I think it's worth at least having an evaluation. Pain management, sometimes, you know, people will sometimes feel like pain management is a last resort, but I would encourage people to think of it as an earlier resort. You know, you can try the sort of the stretching and, you know, and certainly physical therapy and NSAIDs and, you know, or other, you know, over the counter medicines for a time. But if you're finding that you're having to do this daily, that it's impacting your function, your quality of life, your sleep, then I think it's time to go see someone. And you don't have to do anything. You can just see what's going on, maybe get an MRI, listen, think, okay, well, now we know. And in the future, if anything gets worse, you know, I can come back and we'll talk about some treatment. So
We hear, I think everybody has probably heard the term regenerative medicine.
yeah,
And so I think there's this idea that things as science and technology get better might actually be able to improve.
right.
So what what are you seeing there in terms of functional and regenerative medicine?
Yeah. So I think functional and regenerative medicine is going to be hopefully the way of the future in a lot of areas. I don't think it will be the only treatment options, but I hope that it will be more available to people as treatment options, because I've seen a lot of success with regenerative medicine treatments, like stem cell injections into the joints, various joints, into the discs, in the back. Those types of treatments have been particularly exciting because they kind of call on your body to heal itself, and so you're avoiding chronic steroid use that can wear down your bones over time, cause diabetes, you know, lots of different complications. And in the discs in particular, we have not had hardly anything really to treat degenerative disc disease, and especially these annular fissures or annular tears, little tears in the discs. Extremely painful, hard to treat, not really a lot of options for it. And stem cell injections have shown to be successful for that. The problem is they're not covered by insurance. This is considered experimental, and there has been a lot of data showing promising results, but and I've seen it in my practice, but it's an out-of-pocket expense, and so a lot of people can't afford that, and hopefully that will change one day. With regards to the functional medicine, there are functional medicine specialists, and so a lot of patients that I see, I talk to them about seeing a functional medicine specialist to see if we can kind of put everyone's heads together to see if there could be other causes of pain, hormone imbalances, and and you know, low testosterone and different thyroid diseases, autoimmune diseases, that could be possibly causing their pain. And so if we can find maybe the underlying source, often just changing diet alone, anti-inflammatory diets, people probably hear a lot about those, but that's a gluten-free diet, vegan diet typically, at least dairy-free. These have been in patients that have pain, not necessarily everybody in the world, but people that hurt. It is worth you know, trying that for 3 months and seeing is your diet contributing to a lot of your pain conditions. I think that, and then, you know, running a set of blood work to see about different hormones, replacing those hormones, replacing magnesium, that low magnesium contributes to pain, low vitamin B12 and vitamin D. All of these cause pain and increased risk of fractures and things like that. So optimizing all of that, I think, is an important focus, and so we try to kind of do that. I do some in my clinic and plan to do more of it. and work with some functional medicine specialists to make sure that's optimized as well. Um, so it, the idea, I think, with chronic pain and pain management is this multi-modal approach. So often it involves rheumatology, seeing if there's some autoimmune inflammatory disease going on, neurology, and functional medicine, orthopedics, pain management, kind of everyone together. You can often find the underlying source. That's the best situation, and then you can treat it. Preventative medicine, we can talk about that in these, in the functional medicine evaluation too. But then once you have the pain, maybe the interventional things to see if we can treat it, the pain where you end up with it.
That's a really comprehensive answer.
Okay.
No, but
Yeah.
that's great because what
Yeah.
it illustrates, it's not just take an injection, feel better.
Oh, yeah.
It could be your diet, it could be supplements, it could be hormones, it could be certainly stretching and preventative things that people talk about. There are also a lot of interventions, which is very hopeful.
Yeah.
I think everyone hears about stem cells now, and
Yeah.
I would say probably in the last 10 years, the commonality of stem cells has just dramatically increased.
Right.
Um, if I asked you, just give me for the people who maybe just aren't familiar, they've heard the term, aren't sure. What is it? What is a stem cell?
So a stem cell is a cell that sort of starts as the very beginning of a cell when it can become any other type of cell. And so it is the precursor to a lot of different types of cells. So the idea of putting a stem cell in an isolated area, that's why we put it in a joint or a disc. I'm not sure quite about the degree of science yet behind kind of IV infusions of stem cells. I'm sure there's a lot of research going on into that, but I think in a contained space where the replication of the cells and the changing of the cells is going to stay more in a confined environment, that offers the opportunity for a cell to become any sort of regenerative, kind of reparative type of cell that you need in that space, depending on if you have arthritis and it's inflammation and you're trying to combat that inflammation and recruit other types of cells, or to repair a torn ligament or tendon or disc. It has the ability to kind of replicate in different ways and in different forms to do what you need in that area. So rather than just treating the inflammation, then it can actually treat the underlying source of the pain so that you don't continue to get that inflammation.
It's almost like, correct me if I'm wrong,
Mhm.
but it's almost like perceived to be a magic healer. Like if you have a knee injury,
Right.
you could inject a stem cell into the knee, and the thought is it could help repair that
Yeah.
injury.
And it actually can. And so it is not guaranteed. It
Sure.
doesn't always help. So I think when you're paying a lot for stem cells because it's expensive, then that's a tough thing to know that this may not. We don't know enough about it yet to guarantee that it would repair it, but I think it has a much higher chance than anything else we've tried, and has been tremendously successful. It's often do stem cell injections into the knee, and they help for years. Before it may help delay, when you need a knee replacement, or it may repair a tear, so you don't have to have a surgery. But it is not 100%. So you have to kind of be in a place where you give it, you're willing to give it that chance, and then to pivot and do something different if it doesn't work.
I think people would be I work in sports media primarily. I think people would be very surprised if they knew how many athletes regularly
Get
stem cell injections.
I agree.
It has become more common than not.
Right.
And I know in the onset of the stem cell conversation, there was sort of this. Some people had a moral question if because you had
Correct.
to use embryonic stem cells, but
Right.
now there's amniotic
Right.
stem cells. There's stem cells from fat tissue. So
Right.
a lot of that a lot of that question has really been eliminated.
Yeah.
Um, what other advancements with respect to stem cells have you seen? I mean, let's say just in a decade or half decade.
Yeah. I mean, I think there are huge advancements in the ability to obtain stem cells because um, you know we can do a bone marrow biopsy on a patient and take their own stem cells,
Mm,
and then there are no moral questions with that at all. It's a procedure to just kind of tap a needle into the pelvis to take bone marrow out and spin them down and inject them right away into joints or discs. If anyone has is concerned about stem cells or where they came from, um, you have the option to do something like PRP, where you take your
mhm.
blood from your arm, spin it down with a machine while you're sitting there, and inject the platelet-rich plasma into joints as a less expensive alternative, but also very effective alternative for stem cell injections. So we have a lot of different options in that area as well.
You do PRP as well?
So I don't, I did in fellowship, but
Mhm.
my colleague, Stephen Etheridge, I don't know if you
Sure.
talked with him at some point. He does a lot of this and he does it in his office. So I send patients to him for that. And he does a lot of PRP stem cell. He has,
Mm.
very, very busy regenerative practice. And that's exciting because he's seeing a lot of great results.
It's interesting to it's called what's that spins it? It's a
Centrifuge, yeah,
to watch the centrifuge spin the blood to
yeah,
remove. And the way it was described to me, this kind of gross, but like if you have a scab, and if you knock the scab off, there's kind of like
coagulation,
yeah, that is like
yeah,
that's the plasma.
the thick, yes,
Yeah, that's
right,
the stuff that they're basically
right,
taking and injecting.
right.
It's just the body's healing.
Healing properties,
Healing. There
exactly.
you go. So
Yeah.
it's naturally you would be able to say that way,
Yeah.
way more eloquently
No,
than I could. Um, I know another big topic with respect to healing and pain management is medical marijuana, which has
yep.
become far more accepted. I don't know that I have all the research in front of me, but a majority of states now do allow some degree of legalized medical marijuana.
Correct.
Do you feel like the first of all, does it work?
Absolutely. For so many patients, it has been tremendously helpful. It does not help everyone, but nothing helps everyone the same. And it may be that there are different, variations, different types of medical marijuana that may, you know, but uh, but it has been it's been an option, a non-opioid option that I think has been very important to have available for patients. I've seen patients stop taking their opioid medications because the medical marijuana has helped them. I mean, many patients that have been on it for years and years. I've seen patients stop taking their benzodiazepines for anxiety because
Mm,
medical marijuana helps anxiety as well. I've seen patients get off of Ambien for sleep and things like that because medical marijuana helps sleep.
mm,
It's something that is unique in that it's a natural product, so it's safe with almost all medications, other medications. So people that are on blood thinners and people that are on lots of other medicines, you don't worry about interactions. It is something that you don't have to smoke. So I tell people it's just a drop under the tongue or gummies, or they have like a little honey and things like that. So I think in terms of route of administration, a lot of people are worried, oh, I don't want to smoke marijuana. I'm like, no, I don't want you to smoke marijuana either. This is just a natural product that is safer than over-the-counter medicines. A lot of times it's at least not hurting the kidneys and the liver and the stomach lining. as long as it doesn't cause any cognitive side effects. For a lot of people, it doesn't. They can take it in a low dose and they do not feel that it impairs them in any way or their head in any way. Even patients, over 90 years old, when other medicines really aren't options for them, procedures, aren't options for them, surgeries aren't options, then it's allowed them some quality of life, sleep, comfort, and the the ways that it treats pain has been interesting to see. It helps with nerve pain, especially nerve pain, but it also helps with joint pain. I've seen patients that need joint replacements, like a shoulder replacement, and can't have it because of their heart or their age. And medical marijuana has resolved their shoulder pain. They're like, oh my gosh. So that's exciting. It's just worth trying. If it doesn't help, then we can find something else. But if it does, it's been pretty life changing.
Um, you mentioned, so that's probably another big misconception is, do you have to smoke it? So you mentioned a lot of different ways to ingest.
Yeah.
Is the efficacy altered by the manner in which, I guess,
Yeah.
is it more effective if you smoke it or take a
Yeah.
gummy as opposed to a drop?
Yeah. A lot of people will say, I think that the routes of administration do affect maybe how fast the medicine is taken up.
Okay.
So, but it depends on the person, their pain, their type of pain, and their biochemistry. I mean, everyone's different. You process plants and medicines differently. But in general, I think the tincture, the oil, is a little slower onset. So it's more of a maintenance or a daily kind of slow kind of release dose. The gummies or the honey, and they do have a vape, the kind that you can smoke, and it the vape pen that will be a faster onset because it's going through the mucosa or the lungs, and that is faster than the slower release kind of drops. So yes, they can all work maybe differently, and I tell people it's worth trying a different product and different route of administration if you don't like a side effect of one, or if it doesn't help, because there are so many. I mean, I don't even know how many options out there. But where we prescribe it is to somewhere. The medicine or the marijuana is grown at LSU. It's very safe. It's it's only dispensed in maybe 6 dispensaries in the state. So you're not ordering it online, and it's not it's controlled. So it also doesn't have the hallucinogenic properties of typical marijuana. So when you think about marijuana from the 60s or off the street, it doesn't have the hallucinogenic properties that tend to make people anxious or paranoid, or that they may not have liked that experience. That intentionally is not part of the medical marijuana. It is a very different medication, and I sort of wish they'd called it something different, because then we can just start fresh and say, hey, this is a non-opioid medication option. Let's see if it helps your joint pain, your nerve pain. But yeah, I found a lot more people open to it when they realize, like, oh, okay. So this is different. This is something that I could at least just try, see if it helps. If it doesn't help, don't take it. And but yeah, I've been very impressed. And I was a little slow to prescribe it because I wanted to make sure it was legitimate, and it's kind of been the only thing that helps certain patients, and that's exciting.
If there's one big takeaway, I think, from our conversation, it's that when it comes to pain management, there is a vast amount of options, and that there's no reason to sit and live in pain and have your quality of life affected.
Correct.
So I'm going to book an appointment with you as soon as we're
Yeah.
done here. But if I did ask, if you try to look ahead, which is a tough question, obviously, but in 5 years or 10 years or beyond, what in anesthesiology or in pain management makes you excited about where we're headed?
Well, I think that it's exciting that we're exploring different different pain etiologies, kind of where is pain coming from from a functional standpoint. How can we prevent it earlier? We know that it's genetics most often that cause pain, chronic pain. Most people have a genetic component. So I don't think we fully understand or have explored that genetic link yet. And if we do, that may open a lot of doors for treatments very early on, if we know. Also, certain types of work, labor, hard labor jobs, things with a lot of bending and lifting. But then there are newer treatment options with the Intercept that may address some of those types of pain earlier on and then allow people to function longer even in those fields. Obviously, at the same time, we talk about, core strengthening and proper lifting techniques and things like that. And, but all of that can kind of go together. I think with the stem cells, better understanding of long-term ramifications will be helpful, and especially really pushing to get more insurance approval, earlier approvals for certain treatments for pain would be very helpful for people to have access to them. That's been a difficulty. But I don't know. I've read recently about ozone treatment. A lot of athletes are using ozone injections, and they're using this in Europe a lot. It's not FDA approved here yet, but it's very exciting. And the idea is to inject ozone, a free radical, into the joints or discs or ligaments, or even through an IV for autoimmune diseases, for inflammatory conditions, for tears, and it works in a similar way to stem cells, and in the way that it attracts your body's natural healing properties, and has been very safe, at least in Europe and the cases that we've had here. We just don't have the research yet or FDA approval for it, but I think there are a lot of things like that on the horizon. And just kind of checking in early with someone and saying, okay, hey, let me know if you see somebody like me where something helps. Give me a call, or call back in a year. Hey, is it, have you found anything that helped this or that? I have patients who do that, and often we can figure something out that gives them some relief. So
Your education continues.
every day. Yeah.
This has been enlightening. Thank you so
Yeah.
much for the time.
Thank you.